Good morning, everyone from Chicago. I would like to comment on a variety of studies that have been presented here at the annual ASCO regarding non-small cell lung cancer. I have selected 5 studies to be discussed. The first one is the final results of the Paramount study. In first line, the Paramount study used cisplatin pemetrexed as an induction chemotherapy for 4 cycles, and then patients were randomized to maintenance pemetrexed or placebo. We have seen already the progression-free survival data with a favorable hazard ratio of 0.6, but we were all waiting for the final results of the primary endpoint, overall survival. And actually this endpoint was met with the median overall survival of 13.9 months with maintenance pemetrexed versus 11 months for the placebo arm. And this gives a hazard ratio of 0.78 that was significant, the 2-year survival being 32 versus 21%. If we looked at the overall survival from the inclusion before the 4 induction cycles, not at randomization, the numbers are 16.9 months with maintenance pemetrexed versus 14 months, and all subgroup benefited. Post-treatment second line were well balanced in in both arms, and all subgroups analyzed benefited from the maintenance pemetrexed. So I think this is establishing a favorable effect of maintenance pemetrexed after induction pemetrexed cisplatin. These data have to be put into perspective with the AVAPERL study, which was the same design, but the maintenance was either pemetrexed or bevacizumab combined. So we don't have the final results of this study yet, but it will be interesting to see whether bevacizumab brings something else. The second study of interest was presented by Dr. Lillenboom and was dealing with patient performance status ECOG-2 and compared the use of carboplatin pemetrexed versus pemetrexed in ECOG-2 on a number of 161 patients, the primary endpoint being overall survival. There were 80% of patients with non-squamous histology and 77% of smokers in that study. And actually, the combined use of carboplatin and pemetrexed showed superiority in terms of response rate, 22 versus 10.5%, and improve PFS of 6 months versus 3. That was significant at a hazard ratio of 0.46. Overall survival was also increased from 3.1 to 5.6 months at a hazard ratio of 0.57, showing significance. So this study shows that in patients with performance status ECOG-2, the combined use of carboplatin and pemetrexed first is feasible in terms of tolerance and improve all usual endpoint, response rate, progression-free survival, and overall survival. All patients benefited, all ages, including the elderly above 70 years old, as well as the smokers. And this trial, in addition to the French trial that was presented by Elisabeth Coix last year, using weekly Taxol versus carbotaxol in elderly, actually almost identifies a group of patients, including the elderly and the poor performance status ECOG-2 patients, and those 2 studies combined shows that carboplatin can easily be added to pemetrexed in this study from Lillenboom, or to Taxol in the French study to provide a benefit. There were also additional studies in second line. One of them is the Taylor study that was done by an Italian group and presented yesterday by Dr. Garasino. The Taylor study compared erlotinib to docetaxel in second line. We know from the old BR21 study that erlotinib is superior to best supportive care, but erlotinib was never compared to docetaxel in second line. So this is a study on about 300 patients, and there were the majority of adenocarcinoma, again 72% smokers, and it showed actually that the response rate was improved with docetaxel as compared to erlotinib, 14% versus 2.3% at a significant p-value. The PFS also went from 2.4 months to 3.4 months with a hazard ratio of 0.69 showing significance. The study is not mature enough to provide data on overall survival. The problem with that study is that it's a smaller study. It's an investigator-sponsored study. There was no central review for progression-free survival, so we do have to wait for overall survival to make sure that there is no bias. And surprisingly, the chemotherapy arm with docetaxel did very well, with a 14% response rate in second line, which is higher than what we generally see. And there was surprisingly between 2 and 4% of complete response rate, which is very unusual. So I think we do have to wait for the final analysis and the overall survival in that study that shows that docetaxel at the present time would be superior to erlotinib. Another study was presented by Dr. Kim from MD Anderson, the SELECT study, comparing the addition of cetuximab to either docetaxel or pemetrexate. They reported here only on the pemetrexate group of patients. This was in second line, and there was more than 600 patients accrued in that study. And in second line, with single-agent pemetrexate, there was no benefit from the addition of cetuximab to chemotherapy on either response rate, progression-free survival, or overall survival. So this clearly is different from what was reported by Robert Pirker in the FLEX study in first line with vinorelbine cisplatin. They looked at a subgroup analysis, and they didn't find any impact. There was no selection on the patient on the EGFR expression, but they have looked retrospectively at tissues, and the EGFR immunohistochemistry staining 0, 1 plus, 2 plus, 3 plus didn't make any difference. Unfortunately, and as opposed to what was shown in FLEX, they did not calculate and report it so far the H-score with the usual cutoff value of 200, and these results are pending, and they may be interesting. So in second line, based on this study, which is presented in a preliminary fashion, there is no benefit from the addition of cetuximab to pemetrexate, but more biomarker study should be performed. And finally, the last study on which I would like to comment was the use of a new drug, selumetinib, combined to docetaxel versus docetaxel, again in second line, that was presented by Pasi Jain, in KRAS mutant. So this is the originality of that study, dealing with KRAS mutant, for which we don't have much targeted agents. Selumetinib is a MEK inhibitor. It is active on MEK1 and MEK2. It's a rather small study of 87 patients, including 88% of smokers and 80% adenocarcinoma. And in that study, the addition of the MEK inhibitor selumetinib to docetaxel in second line improved overall survival from 5.2 months to 9.4 months. This was not significant, but the hazard ratio is 0.8, and the sample size may be the issue here for the non-significance. To the opposite, on progression-free survival, there was an improvement from the usual 2.1 months median PFS with docetaxel to 5.3 months, a hazard ratio of 168 with statistical significance at p0.01 in favor of the addition of the MEK inhibitor selumetinib to docetaxel. In terms of response rate, there was a very high response rate in selumetinib plus docetaxel, 37% in second line, and surprisingly, in this patient of KRAS mutant, docetaxel single agent had a response rate of 0%. So this was very striking. It is the first randomized trial, to my knowledge, of selumetinib as a MEK inhibitor in second line in non-small cell lung cancer patient with mutant KRAS, and certainly deserves a larger study. With that being said, I think we had an interesting sessions on non-small cell lung cancer that may allow practice changing, especially for the maintenance treatment with pemetrexate. Also in the fragile patient with ECOG performance status 2, and with the limitation that I mentioned, the use of docetaxel and erlotinib in second line may be modified. Thank you very much and have a nice day.